So good afternoon, good evening to those of you who have joined us. Thank you for joining us for today's webinar, review of PES and AHA ASA Guideline and in clinical practice. I'm Emily Hostetler. I lead global marketing here at Phagenyx, and I'd like to introduce our speakers, Dr. Ann Alexandrov and Alyssa Good. Dr. Alexandrov is a professor at University of Tennessee Health Science Center, a professor and program director for the NetSmart program, a past president of ANVC and AACN, an editor-in-chief of Stroke Clinician, and she will be presenting data from her recent poster, Health Economic Implications of Dysphagia in the Treatment of Stroke Patients, which she presented at the International Stroke Conference in February, and will also be sharing a review of PES in the recently published American Heart Association, American Stroke Association Guideline, which she co-authored. Alyssa Good is a speech pathology clinical specialist at Prisma Health Midlands in South Carolina, and she's also an adjunct academic professor at University of South Carolina. She's going to be sharing her experience with bringing Phagenyx into her facility and is also going to be sharing real-world clinical data from her facility. From the Phagenesis side, I'm joined by another Alyssa, Alyssa Cook, who, like Alyssa Good, is also a medical SLP and leads our team of therapy development specialists. Please submit any questions you have on the chat, and Alyssa Cook and I will be monitoring those throughout the webinar. We do have some planned time at the end for Q&A after the presentations, and we'll answer as many questions as we can at that time. So with all that being said, I'm going to pass it off to Dr. Alexandrov.
Well, hello, everybody. I'm thrilled to be talking about this today. The only disclosures that I have are as follows. First of all, I was on the writing committee for the American Heart Association, American Stroke Association guidelines for the early management of acute ischemic stroke. And I was the primary reviewer for the dysphagia and the nutrition sections of the guidelines. And the other thing I just want to emphasize is I am not a speech and language pathologist. So I have not ever given Phagenesis or Phagenyx treatment. So I'm going to actually be leaning pretty hard on the Alyssas that have joined us today to answer questions about that. And lastly, I do want to also emphasize I am not being paid to be here. I am here just because I feel very, very passionate about this treatment and its importance in acute stroke management, not just ischemic stroke, but also intracerebral hemorrhage patients. So this is a prevalent problem. At any given time, there's about 10 to 40% of patients that have had a stroke that develop dysphagia. And the new incidence of dysphagia has been cited to be as high as 80%, especially in your intracerebral hemorrhage patients. And of course, this is associated with tremendous complication risks, including hospital-acquired pneumonia, which is really what all of us should be calling pneumonias when they develop in our patients, unless you actually witnessed the aspiration. That's how it's defined. Of course, we don't often see that. People tend to just use the term aspiration pneumonia. But then also malnutrition from being underfed, and dehydration along with that is very common, as well as higher mortality rates in these patients. And there's certainly nutritional and behavioral interventions that have been implemented for years in these patients, but they've really done little to reduce dysphagia severity prior to the time of discharge. In my own sites, when I look back at patients with dysphagia, it seems like just about 100% of these patients that had a feeding tube during their admission ended up discharging with a PEG. And that's pretty frightening, unfortunately. And when you think about then what dysphagia does to quality of life for patients post-stroke, it certainly worsens it, and especially the social isolation that is tied to dysphagia. Imagine not being able to sit down and have a meal with your family, especially during holidays, for example, because you're tube fed. And of course, the caregiver burden goes up substantially. Next slide. So, what I want to share with you are some data that are reflected in a new manuscript that's under review right now. Hopefully, will be published very soon. But I presented these at the International Stroke Conference for our team, and we're supported by some wonderful health economists to really create this paper. We looked at both acute ischemic stroke and intracerebral hemorrhage patients, and then we stratified the findings that we had in terms of the cost of dysphagia by the presence or absence of it. So obviously not every patient has dysphagia, and we looked at the ones that didn't, the ones that did, but then also by pneumonia and also by whether they ended up with a PEG tube. Pneumonia included both aspiration and nosocomial pneumonias, and we excluded patients with trachs. We looked at a number of different outcomes, as you can see, length of stay for both the total hospitalization and the ICU, and then the costs, which we derived by converting the charges that were sent into Medicare to the cost to charge ratio that is sourced by the Centers for Medicare and Medicaid. And then we looked also at reimbursement, survivor discharge disposition, and then lastly, headroom. So the financial headroom is the reimbursement minus the cost, and you'll see that in the data as well. Next slide. This is very dense, and I don't expect you to take it all in, but if you look at the column over on your left, what you've got are all of stroke patients first, then stroke patients with no complications, no dysphagia, followed by stroke with dysphagia, followed by stroke with pneumonia, and then stroke with PEG. And these are non-trached patients. So looking first at stroke with no complications, you can see here that the costs are pretty much in a loss when you compare it to what you're reimbursed from Medicare by. The costs are sitting right there in the middle, and your headroom is where you're looking at your losses all the way to the right on that diagram. And this was a huge N in this study. The total number of patients was just about 600,000 that we looked at. Now, when you start adding stroke with dysphagia, stroke with pneumonia, and when you get to the worst, stroke with PEG, I want you to look at the last line here that is highlighted in red. And stroke with PEG, the financial headroom is a significant loss. So keep this in mind, because I know that different hospitals around the country that I've been affiliated with are all going, oh my gosh, this is going to cost money to implement something like pharyngeal electrical stimulation. But look at the cost to you if you don't do something to try and improve outcomes in these patients. You're already at a significant loss. And if you can perhaps discharge faster, if you can discharge without dysphagia limitations that are causing the patient to have a PEG, then you're probably going to end up in a better situation. Next slide. Now, this is actually a regression analysis that we did looking at the relationship between length of stay and cost. And when you start first looking at the acute ischemic stroke, which is the blue line, on day one, you're looking at a cost of about $7,730 just with the patient being admitted to your hospital for an acute ischemic stroke. But you'll see it says plus $2,167, and that is $2,167 for each day beyond that first day that that patient is in the hospital. So as your length of stay goes up, your costs for acute ischemic stroke go up. And of course, when you look at intracerebral hemorrhage, which is always going to be more costly than acute ischemic stroke, now you're talking about that first day cost of about $10,500 plus dollars. and you're adding $2,374 a day that patient stays in. So again, very expensive care. Next slide. This is looking at cumulative density function curves, and probably the two to look at most easily are C and D. C is looking at just patients with acute ischemic stroke. First of all, if they come in and they don't have dysphagia, which is kind of hugging more that top left-hand corner of the curve. Next is dysphagia, the blue dotted line. Next is a patient with acute ischemic stroke with pneumonia. And lastly, moving all the way to the right on that curve is the acute ischemic stroke patient with PEGs. And the closer you move to the right side of that curve, the higher your costs are. And you can see the same thing for intracerebral hemorrhage. Again, the more you move to the right side, the more expensive, and PEG patients cost you a great deal of money. Next slide. So let's now get into the guidelines and what we did in the guidelines. If you look at the 2018-2019 update of the guidelines, there was no therapeutic intervention at all that was shown to reduce dysphagia severity or to decrease the risk of aspiration. The focus was mainly on diagnosing the patient and keeping the patient NPO, and really, just focusing on that screening piece as well as some, oral care to try and reduce the risk for pneumonia. So the guidelines for 2026 are quite different because they add number 5 and number 6 that are outlined in that turquoise box. And this is the exciting part to me. In looking through the data, it was clear that PES, or pharyngeal electrical stimulation, was something that really belonged in this new guideline update. And the first one, which both of these are class of recommendation 2A, level of evidence BR, and I'll explain that in a minute. But in the first one, it talks about in patients with stroke with dysphagia that using pharyngeal electrical stimulation can be beneficial to reduce dysphagia severity and the risk of aspiration. The last one actually looks at those patients with very severe dysphagia that end up being trached and mechanically ventilated. That in those patients, after they've been weaned from mechanical ventilation, that it also reduces dysphagia severity and decreases aspiration risk, but it also expedites decannulation, which is very exciting to see that. Next slide. So, what does this whole process look like? Well, it's a volunteer led writing group. We are not compensated in any way. And the American Heart Association goes out of their way to make sure that there's no conflicts of interest among the writers. And they're also looking at every industry reported compensation that's out there. And this is publicly available information, and you'll find it actually in the guidelines themselves. It'll show you who's associated with what, and when you were excluded from any decision making on the guidelines if it had a conflict of interest. The next process was that you were assigned different things. As I said, I was assigned dysphagia as the primary. There were other people assigned as secondary. And we looked at the previous guideline recommendations and the supporting evidence for that. But then we took a very deep dive into the evidence to see what we could find. Because our job is to try to ensure A, accuracy in what we write, but secondly, that we're closing gaps in knowledge when we can, and instead just being more prescriptive about certain things that are important to care. We looked at both clinical trials and we looked at observational studies. And of course, the clinical trials carry the greatest weight. in any guideline recommendation. And we were given a cutoff date of March 2025. So anything published beyond that point could not be used in our writing of the guidelines. And I'll talk more about that in a second. But we then proposed recommendations with all of our supporting evidence. And importantly, every single author on the guidelines had to agree unanimously with what was being proposed. Following that, it went out to two external non-writing group peer review panels. And those peers then did their own review of everything that we had written. And if they had any recommendations that they wanted to change, those were put forward and the guidelines were considered for revision again. So this whole process actually commenced in September 2024. Our first draft was completed by February 2025. The first peer review was commenced in April 2025, and the second peer review was commenced in July 2025. It then was accepted for publication in August 2025 and published in January 26. So essentially, as you're looking at the guidelines are really reflective of anything published in the literature in 2024 and behind. So they're called the 2026 guidelines, but you can see that really the process pretty much concluded by the end of 2024 or the very early months of 2025. Next slide. Now, when we use the term class of recommendation, we're talking about the strength of a recommendation for whether it should be used in practice. And you'll note that for the two recommendations on pharyngeal electrical stimulation, they are 2A class of recommendation. And that essentially means that the benefit of doing pharyngeal electrical stimulation outweighs risk associated with doing it. The level of evidence is the quality of the evidence that's used to support the recommendation. And the level of evidence that supports the two PES recommendations is randomized clinical data. And these are not large studies, but they are randomized clinical trials. And so that's why you're not seeing it up at level 1A. If this was a large study cohort that we were looking at in these trials with thousands of patients or hundreds of patients, the level of evidence would have been higher. Next slide. So from the literature then, our guidelines basically reflect the fact that pharyngeal electrical stimulation delivered for 10 minutes per day for 3 consecutive days with the option to treat up to 6 days in a row has been shown to decrease dysphagia severity, reduce aspiration risk, and reduce the time required to successfully decannulate patients if they were patients with trachs. And collectively, these findings then can reduce complication risk and also reduce length of stay. I also put in my slides the nutritional recommendations because there's very specific data written in observational studies that basically shows that we really shouldn't be considering PEG tubes until patients have had tube feeding requirements at about 2 to 3 weeks or so. And so if you think about what it takes to get a patient that is tube feeding dependent discharged in your hospital, it's highly unusual that you're going to get them out before that time. If they've got a tube, then why not go ahead and use a PES tube and see if you can perhaps affect an improvement that would prevent them going on to a PEG. Next slide. So some of the common questions that I know people have approached me with is, why was this even included? The previous guidelines didn't focus on this. Yes, that's true, but the previous guidelines didn't offer the opportunity to do anything innovative and efficacious for patients. And if you think about how significant a medical problem this is, and again, the social isolation alone, makes it worthwhile to consider improving the patient's quality of life. This is something that we really need to consider adding to our treatment arsenal. In fact, we saw it as a writing group and the peer review groups as an incredibly important innovation that we felt was absolutely essential to recommend. I want to emphasize that just because we've recommended PES treatment, it does not reduce the importance of screening and formal diagnosis. But remember that screening, formal diagnosis, keeping the patient NPO, these things do not prevent all patients from getting hospital-acquired pneumonias. And so it's time that we think about this important opportunity that we have to positively impact patient outcomes. The next slide is just my references, which I know you'll probably not be able to read very quickly, but they'll be available to you through the company. And they're also on my guidelines section as well. And now I want to turn it over to Alyssa Good, who is going to talk to you about the nitty-gritty of how to do PES.
Thank you, Anne. And again, I am Melissa Good. I am a speech pathologist at Prisma Health in Columbia, South Carolina. And I am excited just to share with y'all some of my experiences with implementation of PES and some of our patient outcomes since we implemented. So just to start, traditional treatment approaches for dysphagia can include kind of a combination of muscle strengthening or re-education tasks, as well as compensatory interventions. But these two interventions don't address the root neurological cause. So, what I mean by this is, as a speech pathologist, I can train our patients to complete exercises to target muscle strengthening or retraining of those muscles, or I can provide recommendations for diet modifications or safe feeding strategies to help reduce the risk of aspiration, dehydration, and malnutrition. But these treatment options are limited in that there is no evidence to support that they impact neuroplasticity or brain reorganization. Additionally, with the dysphagia exercises that we currently use, many lack validated protocols and they require active patient participation and engagement, which for some of these patients can really make intervention challenging to deliver. Specifically, some of those challenges that I encounter with stroke patients when I'm working with them is that many of them, in addition to having significant dysphagia, also have language and cognitive impairments that can impact their ability to participate in exercises and in treatment. So they may not understand the purpose of the exercises. They may not be able to follow the commands needed to complete the exercises or to participate in goal-directed behavior. So what can often happen is that we evaluate patients. We determine that they have severe to profound dysphagia. And we follow up, we attempt treatment, and they're not able to participate in treatment either at a level of intensity that we would need for them to get better and get stronger. And it often results in this kind of wait and watch approach because of these limitations. So one thing that we've really enjoyed about having pharyngeal electrical stimulation is, for us, it really filled an unmet need by allowing us to provide treatment to our most impaired patients who are not only having dysphagia, but also were having aphasia and cognitive deficits. We were no longer left to wait and watch. And we use it sometimes in isolation, or if the patient is able to do exercises, then we use it in combination. So it doesn't have to be one or the other. It can be used alone, or we can do both. Sometimes we start off with just doing the PES, And then as the patient gets stronger, they understand what we're trying to do in therapy, then we're able to add in some of those traditional treatment approaches. It's been really easy to implement because of the validated protocol, and we like that it can be completed fairly quickly in about 3 to 6 days. So in terms of how does PES work and what is the mechanism of action? So pharyngeal electrical stimulation starts by stimulating the sensory nerves to activate those afferent or sensory pathways in the pharynx. This in turn excites the motor cortex and induces changes in the brain for recovery of the swallow. So, in the research on pharyngeal electrical stimulation, brain imaging was used to identify that target region needed to stimulate and excite the swallow motor cortex. So, activation of these nerves sends impulses from the periphery, from the cranial nerves, specifically the vagus nerve and the glossopharyngeal nerves, to the central nervous system from the medulla oblongata up onto the motor cortex to help re-engage or reactivate this damaged efferent motor pathway, all looking at targeting restoration of the swallowing central pattern generator. So we're trying to restore swallow function from the brain down. So the Phagenyx system includes a catheter and a base station that is used to deliver pharyngeal electrical stimulation. The treatment catheter has two parts and two functions. The main function of the catheter is to deliver the stimulation. It has an outer sleeve which contains electrodes, which you can see in this picture here. If you want to go, oh yeah, do you mind going back? Oh, yeah. I did want to point out here that this is the base station above and then the catheter there. And so you'll actually see that when we come in and do our treatment, we connect these things. So the SLP comes in and connects the base station to the catheter. And we go through a series of tasks which helps for us to determine an individualized, personalized stimulation level for that patient. So the base station, which you see here, typically the SLP or the speech department takes care of that and brings that to the base or to the bedside. And then really all nursing has to do is just make sure that the catheter stays secure, just like a standard NG tube. Okay, if you want to advance. Again here, so I just wanted to point out the catheter here. It's placed like a standard NG tube. It travels from the nose to the pharynx and it terminates or ends in the stomach. The electrodes are positioned in the pharynx to deliver the pharyngeal stimulation at the pharyngeal plexus. So it delivers stimulation to those afferent fibers of the glossopharyngeal and the vagus nerve fibers. And what I really like is they've made it very easy for us to determine that the electrodes are in the correct place. So we have two ways of looking. We have the nasal bands, which are those two black bands that sit just outside the nose. So we can walk in and use those. That tells us, yes, our electrodes are in the correct place. If for some reason those black bands have advanced a little further, we can also have the patient open their mouth wide and we look for those green oral guides in the back of the throat, which again tells us that those electrodes are in the right place. So easy to place, easy to verify placement, and then we're able to come in and determine that the electrodes are in the correct place prior to delivering the stimulation. So in terms of a treatment overview, it's really a four-step process. So first, the catheter is placed transnasally. In our facility, it's typically the nurse that's placing that, and then we get confirmation that the tube is in place, that it's sitting in the stomach. Second, the SLP comes to the bedside. We bring that base station here, we connect it. And again, as I mentioned, we go through a series of tasks which helps us individualize the patient dose. We deliver stimulation. You'll see here that when we do our treatment that we deliver stimulation for just 10 minutes, one time a day. And treatment can be delivered anywhere from 3 to 6 days. If after 3 sessions, we evaluate that more treatment is needed, we can do that. For some of our patients in our hospital that are more profound, we may just go straight through to for all 6 sessions. But once the treatment's completed, if we're not feeding with the catheter, we can remove the catheter. And if we are still feeding with the catheter, that can stay in place as well. So easy to remove after treatment is done. All right, so patient selection has been something that I've had some questions about, and it's really fairly simple. So, if the patient has a diagnosis of a stroke and you determine that the patient has severe pharyngeal dysphagia, we're considering them a candidate or we're evaluating. Do we think that this patient would benefit from pharyngeal electrical stimulation? So we at our facility will perform either a modified barium swallow study or a FEES, the flexible endoscopic swallow study, to determine the severity of their dysphagia. And from there, again, if they fall into that category of severe to profound, we are looking to start PES with these patients. And thinking about who these patients are in your hospital, these are going to be your patients that have poor secretion management, that are increased or at an increased risk for developing pneumonias or being intubated or maybe needing a trach or maybe already have a trach. Most of our patients are NPO or on extremely modified diets due to their aspiration risk, and they're at risk if they don't already have a feeding tube for either needing that or ultimately needing a PEG. So I became aware of Phagenyx when Phagenyx contacted our director of rehab to provide a clinical overview to our speech team. Following that in-service, we took the time to really look at the literature on pharyngeal electrical stimulation. We evaluated our stroke volume, looked at the volume of patients that were leaving with PEGs or that were currently on our caseload with that fell into this category of severe dysphagia. And based on our assessment, we determined that Phagenyx and PES really filled an unmet need for many of our patients. So, timeline for implementation and that approval process will obviously vary based on your institution. Our process was actually led by the rehab department. So, we really had a lot to learn from just a system perspective regarding the approval process. Our rehab manager and myself initially met with our stroke coordinators and our neurology team about starting PES. They were in full support. From there, we went to and presented to our value analysis team regarding potential benefits and cost savings that we thought we may have with implementation. Then Phagenesis came to provide on-site clinical education to our team and to our nursing units. And within a month, we were able to identify 5 patients that we thought would benefit from treatment, and we started to deliver the pharyngeal electrical stimulation. We took this data and we compiled our data. We analyzed how these patients did, and we at this point went back to our value analysis team, to our nursing leadership, our executives, and showed them kind of what our outcomes were. And at that point, we received financial approval to continue with implementation throughout our hospital system. So we continued to treat patients, and we are fully integrated. So one of the things I wanted to share was in those first 5 patients. So following the treatment of those initial patients, chart reviews were completed. We found matched controls for the patients treated with and without Phagenyx to compare time to return to oral diets. We did have to exclude 1 patient who was not able to advance to a diet, but we found patients that were similar based on their age and their stroke type and location. And we found a couple of really exciting outcomes. First, we found that there was a median of 16 days faster to return to an oral diet in the treated group. We had 3 fewer PEGs placed in our patients that received Phagenyx treatment versus the control group. And all of our patients that were treated were on a diet within a week or less of receiving treatment. So In looking at these outcomes, we really determined that having this treatment option in our hospital went beyond just being a powerful tool for treating patients with limited options, but the impacts really went beyond just the rehab department. For our doctors and our nurses, we were looking at PEG avoidance, potential reintubation avoidance. We had a patient that actually was able to get decannulated who prior to treatment was aspirating his secretions. For management and nursing leadership, being able to avoid a PEG and potentially getting a patient's trach removed really opened up many more options for discharge. And so it kind of reduced those discharge barriers, ultimately reducing these patients' overall length of stay. So since then, as of now, we have data on about 28 patients that we've treated. I would say if I had to average, we're probably treating between 1 to 2 a week. And the age ranges of the patients that we've treated have varied. So I kind of showed here that we've treated patients as young as 39 and as old as 88 with a median age of about 62. We've had patients that have been on the ventilator, intubated. We've treated 2 trach patients. All of these 28 patients were in PO prior to PES treatment. And then our stroke characteristics have varied too. So 16 of the patients had ischemic strokes, whereas 12 had hemorrhagic strokes. And then in terms of stroke location, we had 24 patients with supratentorial strokes and around 4 patients with infratentorial strokes. So here I'm just going to share some outcomes that we have for these 28 patients. So following PES, patients were reevaluated using that modified barium swallow study or the FEES study, that fiber optic or flexible endoscopic evaluation of swallow test that we use. And we had several scales that we use to evaluate their outcomes. Their first one here is the functional oral intake scale. And this is a tool that can be used to measure the effectiveness of dysphagia interventions. So it's a 7-point scale that measures a patient's oral intake. Levels 1 through 3 are patients that are still tube dependent or requiring tube feedings, whereas levels 4 through 7 are patients that are having total oral intake as the scale kind of goes up to 7, they're receiving less modifications of their diet. So all of the patients to start were a score of a 1 at baseline. And what we found is that within 24 to 48 hours of our final PES treatment session, 86% of these patients improved by 3 to 4 points, which indicates a rapid ability to return to total oral intake. And even beyond that, some of the patients that we were able to track until discharge continued to improve throughout their stay, just showing that there is a compounding treatment effect as well. So the next scale that we used, and this scale is called the Murray Secretion Scale. It's a scale that we use for our patients who received the FEES study. We looked at the presence of secretions within the pharynx, and with this scale, the higher scores are more predictive of aspiration and pneumonia. And so prior to treatment, 11 of these patients were found with FEES to be aspirating their secretions. Following treatment, we saw that only 7 of these patients were no longer aspirating their secretions. So that showed that we had 64% of our patients improving in overall secretion management and airway safety. In this next slide, you'll see where we took a look at the severity of dysphagia. So the digest is a scale used to diagnose pharyngeal dysphagia. It is a 5-point scale that grades dysphagia from none to profound or life-threatening, and it's based on safety or severity of aspiration and efficiency, so the volume of post-swallow residue after the swallow. Prior to our treatment, all of our patients were diagnosed with severe to profound pharyngeal dysphagia using our instrumental assessments. And then following PES, 68% of our patients had a reduction in severity of dysphagia, improving to moderate or better, with 86% of these patients being advanced to a total oral diet from being MPO. So, another one of our goals or hopes was that after implementation that we would see a reduction in the number of PEG tubes placed. And as of now, you'll see the numbers 25 patients that we've treated. We removed three because they had a pre-existing PEG. So 25 of those patients that we've treated did not have PEGs. And 22 of them were able to avoid PEG placement, which shows 88% of our patients had PEG tube avoidance, which we've been really excited about. Lastly, we've been tracking 30-day readmissions for our treated patients, and 95% of our patients have not been readmitted within 30 days of discharge. Again, you see our number is only 22 because some of our patients have not reached that 30-day post-discharge point yet. And I will say that the one patient that we did have that was readmitted did have a PEG prior to PES treatment. And in looking at the reason for readmission, it actually was a complication related to the PEG placement. So just wanted to mention that there as well.
All right. Thank you so much, Anne and Alyssa, for those presentations. They were really outstanding. So I wanted to pass it back to both of you to ask for any concluding thoughts that you have about each other's presentations or PES.
I think for me, what I'm very excited about, and again, because I'm not a PES user, is that all of the data that we use to put into the guidelines are validated by exactly what Alyssa just showed. So it's nice to see that in real world data, working prospectively, that this thing works. It is again such an important innovation for us to offer our patients.
I agree. I really think for us, Phagenyx and PES has addressed an unmet need in dysphagia care, really allowing us to provide earlier interventions to our patients, not having to do that wait and watch approach, which really compounds disuse atrophy. We now have a tool for these patients, and it's just been really exciting to see our patient outcomes.
It just seems to me if you have to drop a feeding tube in your patient, why not drop this one and give it a
Mhm.
shot? Because it can be used to feed the patient too, right?
Yes, yes. And that's what a lot of our doctors have been doing is waiting to place the NG tube, waiting for that instrumental assessment or for us to come by and evaluate the patient. Sometimes it's very obvious, the patient sounds wet, gurgly, not managing their secretions. And so we're really they're consulting us much earlier. We're getting in earlier, getting those evaluations completed so that we can start the treatment at an earlier date. And to your point, we're able to feed through the tube as well.
Fantastic. I've actually seen a couple of questions come into the chat over the last couple seconds. Feel free to look at the bottom bar of your Zoom, and it should give you the option to drop a question in the chat. So, one question was access to the presentation. There will be a recording of this presentation that we will make available after we go through internal review process and do any sort of edits. And I can certainly connect the person who asked the question with their local rep because one of the things that we have in hand is data for individual facilities that would map to some of the things that Anne presented. So if you're working on ROI, that's something that our reps can definitely help with in terms of getting data specific to your facility in line with what Dr. Alexandrov just presented. How many stroke patients do you have per year at your facility, Alyssa?
That number I do not know offhand, but I can certainly find out. I'm sorry, I do not know offhand.
That's okay. You know what?
I
One
can
of
tell you in Memphis that our largest comprehensive has about 2,200 admissions a year. And that's taking all types of stroke into account. It's an incredibly busy, high volume center. And of those, the ones that are tube fed, I honestly cannot recall a single one that discharged without a peg.
you have around 1,400 strokes a year, Alyssa, in your
Okay.
facility.
No,
So
it's
as
We
I
important.
just
said,
Googled it.
our team does have great data that they can help support facilities that are trying to make the ROI case can help teams. Lissa, do you want to take the next one?
Yeah, so there's a few questions about contraindications. The major ones are if you can't insert a standard NG tube, you shouldn't be inserting our catheter, of course. If there's any changes to nasal anatomy where you wouldn't be able to pass a standard NG, don't pass our catheter. The other two major ones are we haven't been tested in people who are pregnant or children, so those are contraindicated. And the other two big ones are MRI and defibrillation. We haven't tested it, so we can't say that is safe as well. Alyssa, question for you. How has PES changed the relationship between the SLP staff and physicians?
That's a great question. We are lucky. We had a pretty strong relationship prior to, but what I found to be exciting is prior to physicians placing pegs on these patients, they are now reaching out to us and kind of saying, would this patient be, but before we place a peg, would this patient be a PES candidate? If not, why? So we're able to have those conversations. If we identify a patient that we know is going to be a great candidate, but possibly they haven't had an MRI, we're reaching out to the doctors and letting them know as soon as we can get that MRI, we can go ahead and get the treatment started. So there's definitely a lot of really great collaboration going on.
Awesome. There are some questions about who places the catheter and if speech pathology places it. In general, whoever your institution currently uses to place catheters is who would place this catheter. So traditionally at Alyssa Good's site, for example, at most of our sites, it is nursing. However, providers can also place depending on your institutional workflow and processes. Um,
So it looks like we've got some coming into the chat and some
oh,
coming into Q&A.
yes, Theodora, thank you for bringing that up. I did forget this one contraindication. Pacemakers, any implanted electrical device is also contraindicated because we haven't tested them. So Theodora asked about pacemakers. This would also include deep brain stimulators and loop recorders. We can't test every single device, so therefore we have a blanketed, it is a contraindication. Bethany Shipley asked about off-label use for non-stroke patients. So in regards to our US labeling, it is severe dysphagia post-stroke. We have other labeling in Europe, but that is our FDA labeling in the US. Alyssa, you, I believe, have treated just both ischemic and hemorrhagic strokes.
I have,
Perfect.
yes.
Um, it is NFIT compatible. It's so much harder when there's so many questions coming in all over the place.
All of a sudden.
Yeah, Emily, can you help me grab one of these? How has PS changed? I just asked that. If the series of 6 treatments has not been assisted with PEG avoidance, have you brought patients back at a later time to continue treatment? Alyssa, you have not.
We have not.
Um, Do you experience resistance? This is a good question. Do you have experience with resistance from the rehab team due to length of time required for the treatment, Alyssa, or any resistance for any other reason at your institution?
We have not. If there is a pending, discharge, or they're trying to get somebody, out of the hospital a little faster, then sometimes we have repeated that study at that 3-day mark. But for many of our patients, we're getting in the ICU, and so we're able to easily get through the 6 treatments. I
Perfect.
also think that the physicians seeing the outcomes, they may be willing to wait an additional day. Many of our patients, I've had several within the last couple weeks where we repeated their swallow studies and they left the same day. So they had, a rehab bed, really hoping to not have to leave with an NG tube or a peg. And we were able to get them on a diet and they left that afternoon.
Perfect. How quickly are you implementing PES? Do you wait a certain period of time?
So we are consulted on all stroke patients. So, upon admission. So if we are able to see the patients, if they're not intubated, then we are going ahead and evaluating the patients. We like currently we would like for the patients to be awake and alert enough to participate in a traditional swallowing evaluation. So we would like for them to be able to take PO trials, even if it is limited, so that we can get an assessment of their pharyngeal swallow with our instrumental swallow studies. So if we have a patient that's extremely lethargic, we might wait a day or two. That's just currently what we're doing. I don't know that it will always be that way, especially now that we've seen our outcomes. But at this point, we've been waiting for them to be able to participate in an instrumental swallow study, getting that data, determining the severity of their deficits prior to starting. So,
Perfect.
Alyssa, I see one other one that is along the same lines, I think, is the rehab uh, resistance question. So somebody who's just starting the process of trying to bring Phagenyx into the hospital. And first step is getting acceptance from nursing leadership. Did your nursing staff have any issues with being responsible for placing the catheter, or was there any type of other resistance from nursing?
Um, honestly, not at our facility. I think because the nurses are sitting with the patients all day long, hearing the patients, asking when can I eat and drink. They see these patients becoming more depressed because they can't eat and drink. Our nurses were very excited about having this option. Once, they were educated and realized that it is truly place like a standard NG tube. They really were not as intimidated. I did create, cheat sheets for them initially, just kind of going step by step so that they knew how to determine the NEX and they were familiar with the nasal bands and what they were, since that's not on a normal tube. But but really, we have not had an issue with that. I do think providing the cheat sheets and things like that and being readily available to answer questions has helped. But
Yeah, I
um,
would really be surprised if there was nursing
mhm,
resistance because really all of my nursing colleagues have been thrilled to see that this was an option now.
yeah.
So I'd really be shocked if that was an issue.
Alyssa Cook. There are a
Yes.
couple of questions at the bottom of the chat that I think would
Yep.
be great for you to grab, and then I'm going to check the Q&A again.
Absolutely. So, is it required to have an instrumental prior to initiating PES? So, for patients that are not appropriate, probably cognitively, for an instrumental that may still benefit from PES, do you have to do an instrumental? As a company, we do not dictate what you do with clinical practice. It sounds like Alyssa does fees or modified pretty consistently prior, but that is not mandated and you do not have to.
And I know that that
Um,
could be a barrier at some facilities. They may have a limited number that they can do in a day. So I think initially we chose that to do it that way, and it's really made believers, I think, in our staff. It's really improved their support, but it certainly does not have to be that way.
Awesome. Thank you, Alyssa. Um, and then do you have any experience that you can speak to regarding how you're talking about inclusion criteria or who is a candidate is a better verbiage versus who's not, and how you're communicating that with your team, with your medical team, the providers, nursing, etc.
So, as I mentioned, we try to keep it fairly simple, and that if the patient has a stroke and they've been diagnosed with severe pharyngeal dysphagia, we are going to proceed with PES unless. So the reasons why we would maybe hold off are if the patient hasn't received the MRI yet. Loop recorders came up. We've actually talked with our cardiology team. They are okay with us, using it off label. For the patients that we've used it with, we've used it with a couple patients like that. But we do want to check and make sure that the patient doesn't have these implanted devices. If a patient is severely agitated, sometimes we might wait because we don't want them pulling or displacing the tube. Um, if they have pretty profound oral dysphagia and maybe they're just not even able to siphon through a straw or take food and liquid, we might just wait until we're able to get a better assessment of their pharyngeal swallow. But those are really the only things that I'm thinking of that have maybe made us exclude a patient.
Thank
Okay, I
you.
think we have
Yeah.
time for
Awesome.
one more question. I think a couple came in along the lines of one-time use, reinsertion. So do you want to
Yeah.
grab that one and that Alyssa see, and then we can.
Absolutely. So the catheter itself is once you place it, you leave it in place, and that delivers the 3 to 6 treatments. So it's one catheter per patient, if you will. If it does get pulled or dislodged for whatever reason, we have a very strong partnership with our sites, and we work with you to figure out solutions to those very magical patients that can dislodge things despite bridles even. So yes, great question. We work really closely with all of our sites.
Fantastic. And yes, we had a whole bunch of questions come in throughout this Q&A period, so we haven't been able to get to all of them. So we have your information, and we will be able to connect you with our team members based on where you are located, since we will also have your locations. But I wanted to again thank Alyssa Good and Dr. Alexandrov for presenting on this webinar tonight. I really appreciate it. It was outstanding. So thank you so much once again for everybody who attended. And for those of you who sent over questions about whether the recording will be available, yes, it will be. Again, this is something that we will need to uh, review internally, and then we'll be posting it. So we'll notify folks who registered after the fact. But thank you again. And again, if we did not get to your questions, we will reach out to you, or you can reach us at contact@phagenesis.com. So thank you again and have a great night.